Okay. Hi guys. This is my presentation on mood disorders, talking about severe depression and suicide risk. Okay, so in pediatrics, depression presents itself in different ways depending on the age group, which I learned today. So toddlers and preschoolers, they may present with a lack of energy. They really want to please others. They have excessive whining or clinginess to their parent or teacher. And then they have developmentally inappropriate issues with separation. So, separation anxiety is really bad with these kids with their parents. The school age, they're irritable, angry, hostile. They may have that like ADHD hyperactivity, difficulty handling aggression, reckless behavior. They also can be absent from school, or school phobia. And then they have or they could have these internal symptoms of depression, which are tummy aches, headache, muscle aches, or lethargy. And then for adolescents, they're impulsive. They're also very tired. They're an absence from their normal social group. A lot of times there is substance use, aggression, irritability, hypersexuality, and then complete isolation from family and friends. And then for this group in particular, which we know also from our case study, that substance abuse is a significant comorbidity, especially in adolescents with depression and suicide ideation. Okay, so for assessment, um, there are multiple depression ratings out there depending on the age group. So these are the ones I know that a lot in practice. I haven't been in clinical practice, but yet for primary care, but for the PHQ-9, that's the one that most of my peers have been using, and that's what we learned in class. So I put that one up, and that's for ages 6 to 10, and then 11 and up because there's a modified for teens version. So I know that that's used a lot. And then I did like the child behavior checklist, which is geared towards the younger population, and then it has a separate for the older. And then the children's depression inventory goes through 6 through 18. So I thought it was a long span. And then I found that the Reach Institute produced a toolkit called GLAD PC, which is how you can approach treating and managing depression in primary care pediatrics. So I thought that was super helpful. They have VISs that are screenings that are in different languages on this tool. So I left it here, but I'm going to attach it and send an email to you guys because I thought this was so helpful and I'm going to use it in my practice, hopefully. And then for diagnosis, so these are other the differentials that could mimic depression. So infection, lead intoxication, anemia, eating disorders, mitral valve prolapse, premenstruation syndrome, and some neurologic disorders. Also our book, and I know this too, is that some medications can have side effects of depressive symptoms. So you have to screen which medications your patients are on, to make sure that med is also not giving them depressive symptoms. And then for the medical diagnoses, they are all, the criteria is all according to the DSM-5. So we'll look at those. All right. So for major depressive disorder, from this list of symptoms, you have to have 5 or more, and they need to occur in the same 2-week time period that represents change from a different level of functioning than prior. And then depressed mood or loss of pleasure are the 2 symptoms that you need to have, and along with these symptoms. So depressed most of the day, diminished interest and pleasure, all activities, weight loss when not dieting, weight gain, or decrease or increase in appetite every day, insomnia or hyperinsomnia, psychomotor agitation or retardation every day, fatigue, feelings of worthlessness, and then the recurrent thoughts of death, but not attempting suicide, is in this, or having a plan is actually in the DSM-5 criteria. And then so suicide behavior disorder, the patient to rule in for this diagnosis they have to meet all of these 5 criteria. So if they don't, then they wouldn't apply. So they have made a suicide attempt in at the past 2 years. Um, it's not it's different than self-injury, um, that is non-suicidal. It doesn't contain suicidal thoughts or preparatory acts because that's back in our major depressive disorder criteria. The act was not initiated during a period where they were confused or they had delirium, and then the act was not done with religious or political motive. Okay, so management of care and follow up with this specific population. So the number one emergent priority, if a child comes in with and you screen them and they test positive for depression, um, you want to determine the risk for SI, and you need to intervene to prevent SI at all costs. And then if the patient is proactively, if they have a plan, if they present with suicidal symptoms or psychosis, and there's a risk for abuse and self-harm, they need to be transferred to the nearest emergency room for immediate psychiatric evaluation. Parents and the child, you want to educate them, ensure them about complete safe spaces at the home. So you need to remove any firearms, possible weapons, or lethal medications that they could use in their an SI attempt. As the PDMP, you want to see the patient at least 2 times a week. I know that it might be more, until they have been referred to a behavioral health specialist, a therapist, a counselor, a psychiatrist, just to ensure that that nothing will happen to that child and that you're creating a safe plan of care until they can receive the resources they need, because it's hard to get that right now. And then for both SI and MDD, CBT therapy is the first line treatment, along with paroxetine or Paxil in the pediatric setting. And there are other SSRIs used in pediatrics, but that is what our book suggests as the first line treatment. And then these are red flags for suicide. So the changes in behavior, basically, the child completely switches. So they're risk taking, they're accident prone, they're trying new drugs and alcohol and other or illicit drugs that they weren't doing before. The socialization from friends and coworkers and family is a huge red flag. Um, buying a weapon, journaling, or writing about wanting to attempt suicide. Changes in mood, so they express feelings of hopelessness, extreme rage. Their affect is one way, then to the other on the other side of the spectrum. Episodes of crying, and then their sleep hygiene is usually changed. Thinking their mind is constantly occupied thinking about death and thinking about the suicide attempt, and that it would be better otherwise. They may have irrational speech, hallucinations, and loss of interest in religion if they were religious prior. And then major life events. So if there's a death of family or friend, if parents have separated or divorced, public humiliation, loss of a first love or relationship, loss of financial security, or a serious illness or trauma, or other things that can trigger SI, and they may be a red flag for this. And then these are my references. Okay, I hope you enjoyed. Thank you.